Good afternoon, everybody. In this lecture, I'm going to cover the vestibular and ocular motor systems, some of the background science on those, and then what we can do to rehab those once somebody has a concussion and we're trying to get them back to sport. Now, a clinician who specializes in this type of population, if they watch this lecture, they probably think that I'm hopefully not way off the mark, but that I boil it down to some of the most simple terms and ways of presenting it, because you could spend entire courses and years learning just on this topic. From my background in this area, I learned some of the basics in undergrad here at USF, but it's when I went to go intern with John Hisamoto that I got my feet wet with it. Now, he was doing computerized balance training with an old CANALS system, and he used it to treat not just balance dysfunction, but all of his lower extremity and lumbar patients as well. It's also with him that I learned how to treat BPPV. Then when I went on to PT school, my rotation after my second year was at the VA in Bay Pines, and my instructor there treated all the outpatient vestibular and balance dysfunction patients, along with the standard musculoskeletal issues. At that location, we had a neurocom system for computerized balance, but I also learned this VOR rehab that he uses and how to also incorporate the upper cervical spine for their contribution of symptoms as well. Then while I was still a PT student, I continued to work with John as a tech. And the company that makes the HUMAC Norm isokinetic system that I work with, well, they decided to make a computerized balance system. And it's basically a Nintendo Wii Fit board that they put their own hardware and software into it. And then they sent it to us, and we were one of the beta site tests for them. So now it's available for purchase, and this isn't intended to be a sales pitch. But the nice thing is that it's completely portable in that it just connects to a standard laptop, and it's affordable at about 10% the cost of a lot of the other major balance systems out there. All right, let's move on to the lecture. In the inner ear, there are two major parts, the part for hearing and the part for balance. And we can break the balance part down into further components. Now, this component here, it uses three semicircular canals, and those are called the anterior, posterior, and lateral canals. And these canals are for detecting rotational motions. And you can see in the top right of this picture, the motions in rotation that we have are pitch, yaw, and roll. And if you notice that each of these motions, they're all oriented 90 degrees to each other. And if you look at the three canals, well, they're also in the same 90-degree orientation from each other. Now, each labyrinth, the one on the left and the one on the right, they're also oriented 90 degrees from each other and about 45 degrees from the sagittal line. So that orientation of each canal means that each motion will be detected within the system, with each canal giving a different amount of contribution. Now, how these work is that as your head is moved around in space, a fluid called endolymph flows through each of these canals, and at the end of each canal is a little area called the ampulla. And within that, there's the cupula, which is a sticky jelly that has hair cells or stereocilia that's embedded within it. And then as the fluid flows past that, the cilia detect the direction and magnitude of the motion, and then each sends their information up the vestibular nerve. So just with this system, we already have 6 different inputs that the brain's using to try to figure out our location in space. Also, just anterior to where all these canals come together is the utricle and saccule, and these spaces communicate directly with the semicircular canals through the endolymph. Together, the utricle and saccule are known as the otolith organs, and now they're a little different. They're flat organs covered with the same jelly and cilia, but they're also covered in what's called otoliths, and those are made out of calcium carbonate. Now, each of these is only about 10 microns in size, so they're very small. These organs are different in function in that they don't rely on the flow of fluid, but instead they rely on gravity displacing them, and you can see the lines of movement in the picture on the right. They also don't detect rotational movements, but instead they pick up translational movement, such as going up and down in an elevator or the forward-backward motion like when a car, train, or airplane accelerates or decelerates. These, just like the semicircular canals, they're oriented 90 degrees from each other. Now, if we follow what happens after the signal moves along the vestibular cochlear nerve, you can look at the chart here and we'll walk through it. In this example, the head is rotating to the left, and you can see that with the heavy arrow around the diagram. But the subject, they're keeping their eyes fixed and stabilized on an object in front of them. So the head rotates to the left, and all the vestibular organs on both sides detect the motion, sending their signals through the pons to the vestibular nucleus. And keep in mind, a nucleus is just a group of neurons in the brain that controls something. The signal then goes to the abducens nucleus and then to the oculomotor nucleus in the midbrain. These signals then go directly to the muscles of the eyes to make them move to the right at the same rate that the head is moving left. If we look at the organ on the left, you can see the direction of fluid flow, and the line coming down the tract is colored in red, meaning that it's an excitation signal. So it's going to travel down the line, making the left eye's medial rectus and the right eye's lateral rectus pull the eye to the right and stay fixated on the object. At the same time, in the organ on the right, the fluid is flowing in the reverse direction, and this sends an inhibition signal, and that's pictured in blue. So the exact opposite eye muscles are being inhibited, so that allows the movement. All of this turns the eyes to the right while the head moves to the left to keep the person focused. And this is an oversimplification because in reality, there are 6 eye muscles each, and each of those contributes. And if we throw on top of that, there's even afferent and efferent signals coming to and from the cervical spine, and then everything just has to be timed up and perfectly just for this to balance out. So it's really an elegant and complex system, and you don't even think about it until it's thrown a bit out of whack and you have dysfunction. Now, when our athlete suffers a concussion, you can get the traditional coup-counter-coup mechanism, but when there's an element of rotation that occurs, the brain literally gets twisted inside the skull, and this is going to cause shearing and damage to these tracts, and we discussed these earlier, as well as the normal CNS communication fibers. There are all kinds of pathologies that can affect the vestibular system, from hypofunctioning, Meniere's disease, and labyrinthitis. But what we commonly see after concussion is BPPV, or benign paroxysmal positional vertigo. So after head trauma, or even with subconcussive forces, you can get the otoliths from the utricle to fall off, and then they clump together and displace into one of the semicircular canals. And we call this clump an ear rock, and typically the ear rock will fall into the posterior canal, simply because the opening of this canal is right underneath the utricle, so gravity pulls it down through the fluid. And as they turn their head, the fluid in all 6 canals detects the motion with the fluid flow past the cupula. But in one canal, the little ear rock continues to pull fluid, and this gives a mismatch to the system and the person experiences significant vertigo. This is the most intense when laying down in bed with the head turned to one side. It only lasts about 10 seconds or so before resolving because the little ear rock eventually settles to the bottom of the canal and it stops pulling fluid along. I've even had this before, and it basically feels like when you used to spin around as a kid and then you try to walk straight. And that's not bad if you do it on purpose, but if it hits you all of a sudden for no reason and you're not expecting it, it can be pretty scary. The reason the person feels that spinning sensation is because the vestibular system is connected with that oculomotor system. And when this mismatch happens, the eyes will actually bounce back and forth and twist aggressively, and that gives a sensation of spinning or motion. When you test them for this with the Hall-Pike-Dix position, as they lay back in the first position, you gotta watch their eyes for the vertical direction and a rotation, because that tells you which side and which canal that little otolith is in. With traditional posterior canal canalithiasis, which is the most common form, the eyes are gonna bounce cranially and toward the side of the pathology. Once you identify the correct ear, the correct canal, all you have to do for the treatment is to manipulate the person's position so that the ear rock falls through the canal and back to the area of the utricle. And you can see that in the video for the Epley maneuver. Now you can also get where the ear rock becomes adhered to the cupula, and this is called cupulolithiasis. And that's a little bit different with the signs and the symptoms as well as the treatment, so I'm not going to go into that now because it's not as common. Also, if your athlete has head trauma and they're laying and side-lying when that otolith forms and falls, it can actually fall into the lateral canal, and this has its own assessment and treatment that's different from the regular posterior canal. I'm not going to go into it in this lecture, but if you're interested in learning about it, just look it up or go to a course. So after you get the ear rock cleared out, there are some basic balance and VOR exercises that you can do to speed along their recovery, and I'll teach you those in a few minutes. The longer the person has BPPV, the more the brain is adapted to that new normal and the longer that it's going to take for everything to get used to working as it should be. And I've even had patients who are being treated for a completely unrelated musculoskeletal issue. And when they go to lay down on the plinth, it would trigger their vertigo. And most of them have adapted to it, so they just tell me, oh, it's not a big deal, I just have to lay here for a moment. But then when I tell them that I can actually assess and cure this for them, and then we spend 20 minutes of a session doing it, then I kind of look like a superhero to them. And if you think about it from an injury prevention standpoint, if I can prevent a future fall due to vertigo and then they don't sprain their ankle or get an upper extremity injury, that's a pretty darn good use of those 20 minutes. The typical patient I see with BPPV, they're actually going to be postmenopausal women. And the reason for that is with menopause, there's a bone mineral reabsorption systemically. And since these otoliths are made of calcium carbonate, and since they're always being turned over with some coming off, dissolved in the endolith, and then being reformed, well, if there's an increase in systemic calcium, then that sends the equation out of equilibrium and you get a buildup of the otoliths that clump together and they form that ear rock. But just think about if you had somebody with the female athlete triad and they're having issues with their bone density, that you might actually see this with them. And I posted a quick video link for BPPV and the Epley maneuver that explains all of that. So how do we assess our athletes after concussion? And I posted some YouTube links in the module page, and check those out because they did a great job of demonstrating it. Now you should also be doing your standard concussion assessment, whatever you're currently doing. And you should also be doing a cardiovascular test. So find and document impairments if they're available. Now with anything we treat, you're assessing the athlete every time you work with them by simply doing a subjective feedback. And the key is finding their baseline symptoms on that 0 to 10 scale. And I like to describe that 10 out of 10 here is completely incapacitated with extreme vertigo and vomiting. Essentially, they're stuck to the floor, completely miserable, and they can't do anything. And I usually tell them that between 1 and 4, those are varying levels of dizziness, with about 5 out of 10 bringing in that nausea and kicking in that loss of balance. So find their baseline, but also find out from them what is their acceptable level of symptoms. Some people can barely tolerate dizziness, but some they can tolerate the higher levels of symptoms. So it's important because when you do your VOR exercises, we actually want them working into a tolerable level of symptoms. And while they're doing their exercises, you can ask them what level they're at, and you can determine how much more to push them versus telling them to rest until their symptoms drop back below that level. Also, think about safety. They might tolerate higher levels of dizziness while they're sitting, but if you transition them to standing or a tandem or foam stance, then they might not be able to work into those higher levels of symptoms because of their balance issues. Now, after they're done with exercise, you're also assessing how they're doing and how quickly they're able to get back to baseline. And also keep in mind headaches as well as the inability to eat or sleep that night. If you push them too hard in a session, even though they could tolerate it at the time, well, if they're impaired afterward, you might need to back it down a little bit. When it comes to VOR exercises, we basically have 2 ways to approach it. The first is VOR times 1. And in this VOR exercise, you give the athlete a target to follow with their eyes. In X1 drills, there's only one thing moving, whether it's the target with a stationary head or with a moving head on a stationary target. And keep in mind that you can have multiple targets as well. In X2 drills, both the target is moving as well as the subject's head or body. With both X1 and X2, you start with the most stable position of sitting, and then you progress to the same exercise, but now you do it standing. Just keep a chair or something to catch them in case they fall. After they can do them standing, then you progress them to a tandem stance or an unstable surface like an RX or BOSU. Now, I typically don't use single leg stance just because you have to do it for a minute before stopping, and it's too hard to maintain the position and still perform the exercise for that long. You then move on to walking and moving around, and then you can even progress into running or sport-specific activity. So let's get into some demonstration videos. In this first video, what I'm doing is I'm sitting still and I'm looking with my head straight, not moving it, but I'm moving my eyes back and forth between 2 objects on the wall. Now that object can be a poster, it can be a light switch, it can be a doorknob, it can be a hinge, anything that's at the ends of the range of motion without the person having to move their head. One thing you can do is you can even hand them 2 playing cards. And they hold those playing cards out in front of them and then just slightly outward so that they can flick their eyes back and forth without moving their head. If you don't have playing cards, you can even have them hold their thumbs up and they look at their thumbnails. And you'll actually see me using my thumbnails in some of the other videos coming up. The next exercise is exactly like the last one, but now they're looking up and down. And again, you don't want them to have to move their head at all. So the objects they're looking at have to be within their visual range without moving the head. What some people have done is they also just take Post-it notes with an X on it, and then they can put those on the wall and adjust it to the patient. Next up, what you're going to do is now move the head and the eyes together to look at two different targets. First, we have horizontally, and then we have vertically. Now the key with this is to have the objects spaced further apart, so they also have to move their head as well. Now in this next one, it gets a little bit tough. What you're going to have them do is first look with their eyes to a target on one side, and then move their head toward that target while keeping their eyes fixated on that target. Once they get there, they then flick their eyes over to the second target while not moving their head, and then the head tracks to that other target. And next we repeat the exercise, but we're going vertical. In these next two exercises, you're going to keep the head and eyes completely still, but what you're going to do is move your body. And we're going to first start with horizontal side to side. And the key with this is you're keeping your eyes focused on the target, but now the target is your thumb. But like I said, you could also hold up a playing card. The key with this one is that you're going to stimulate the inner ear, but you're going to keep the eyes and everything fixated on that target. After you do the horizontal component for a minute, you then move on to the vertical. In this next one, the patient's going to hold their thumb or a playing card out in front of them. What they're going to do is they're going to keep that target completely stationary, but they're going to move their head side to side as quickly as they can while keeping either the thumb or the playing card completely in focus. So the eyes are going to stay locked onto that target. And they do this as quickly as they can without losing focus for up to a minute. In this next X1 exercise, we're going to just do the same as the last, but we're going to do it vertical now. So the thumb and the eyes stay fixated while the head moves up and down. In this next one, now we're going to have the target moving while the head stays still. The eyes are going to still keep locked onto that target, and you're going to go as quickly as you can while still keeping it in focus. And now we're going to repeat that in the vertical component. So the target is moving up and down while the head stays still and the eyes stay locked on target. And now we made it to the final X1 sitting drill. In this, the head is going to stay stationary, but the thumb is going to be moving back and forth toward the eyes. It's going to make the eyes have to converge. And now we're on to the first X2 exercise. And remember, in X2, you just have two things that are moving. So in this example, both the head and the thumb are moving at the same time, but I'm having them move in opposite directions. And the key is to keep the eyes focused on the thumb. Now, what you want to do with this is make sure that your head motion is nice and big, but you keep your thumb motion a little bit smaller. That way, there's a maximal amount of stimulation to the semicircular canals. In this next X2 exercise, you're doing the same thing, but now it's vertical. So the thumb moves down while the head moves up, and vice versa. The eyes stay locked onto the thumb. And remember, you can use a playing card as well when you're doing this. So now we've finished all the X1 and X2 exercises in sitting. So now you progress them by having them move to standing. And make sure you have a table or a chair, something that they can grab onto in case they lose their balance. When they can do them standing, you move on to a tandem stance, or just in standing on an unstable surface like an RX or a Bosu ball. After they complete those, then you can move on to the walking ones. So now we're going to do the X1 drills while walking and moving around. So in this first example, you have a target on the wall, and it can be something as simple as a Post-it note with an X or a playing card, something taped to the wall, or you can use a doorknob or a poster. But you have the athlete walk through the clinic or walk through the gym while turning their head side to side as quickly as they can, and they're going to keep their eyes focused right on that target. And what you can have them do is either put a second target at the other side of the room, so when they get down to one end, they turn around and they walk back to the other side looking at that target, and they do this for a minute. You can also just have one target on one wall, and they walk up to it, and then when they get close, they start walking backwards until they get away, and they go back and forth for a minute. In this next exercise, we're doing the same thing, but now vertically. So they're going to be tilting their head up and down. And in both of these, you want to start out slow. So they walk slowly and the head movements are slow. And then as they get better, they try to speed up both the walking speed and the speed that they're turning their head. But they still have to keep that target in focus. And these are the same two exercises, but now I'm using a faster speed. And you should notice that I'm also weaving back and forth because the faster you go, even though it's completely in focus, the exercise gets harder. Our next walking exercise, the head is going to stay still while the target moves. They're going to use their thumb or a playing card. And here we have the vertical component for that. And once they're able to do all these and walking and standing without the symptoms going too high, you can move on to running, to where they're shuffling forward and back while doing the head turns, or doing a side-to-side lateral shuffle with the head turns and locking on a target. You can also have them moving their head back and forth while you are moving around the room as well, or around the gym. You can even have them track a ball, so you're tossing a ball back and forth to them while they're doing head turns, and possibly even doing head turns while moving around, shuffling themselves. Now we're going to move on to two vestibular specific exercises. And even if your athlete doesn't have BPPV, if they have any movement intolerance or they get symptoms when changing positions, these exercises are great for them. I posted a link for the Epley maneuver in the Module 11 page, so check out that link because they do a great job of showing the positions and how it affects the inner ear. But I'm going to demonstrate for you the Brandt-Darhoff exercise. In the Brandt-Darhoff exercise, what they do is they sit on the plinth, and you want to have two sets of pillows, one at each end. And they're going to lay down quickly to one side, and they do this, and then when they're laying down, they have their head turned up to a 45-degree angle. Now, they're going to lay there until their symptoms resolve, or if they don't have symptoms, then they just lay there for about 5 seconds. And then they sit back up quickly to the starting position. And again, they wait for symptoms to resolve, or if there's no symptoms, they just wait for about 5 seconds. Then they go to the other side. And again, you want to have the head rotated up to about 45 degrees. And they're going to go back and forth like this for about 20 repetitions. Now, they might not have symptoms initially. Sometimes people only get symptoms after doing this 3 or 4 times side to side. Lastly, I want to discuss computerized balance training and testing. And most of you won't have access to this. But if you do, it's huge for getting your athletes back to play. There's a few brands out there that make these devices, but the ones I've used the most is the HUMAC Balance System and Kincom. Now you can use these for balance testing, in which you have a baseline at preseason, and then you have a post-concussion test, and then return to play testing. But they also have training and exercise applications that are really helpful, and I break those down to center of mass weight control, predictive balance training, reactionary balance training, dual task exercise, where you have them do these exercises while naming lists or doing math problems. And you can also have them play games on these devices. I have a few videos here to demonstrate just a few of the activities. And this is the clinic where I was the director of outside of Nashville. And David here is demonstrating an exercise in which he keeps his sway indicator marker on the target dot. And as that dot moves around the screen, he has to keep locked on. And he's on a moderate level difficulty, but you can adjust how far the area of sway is. You can also make it so the target moves around randomly, or it will have multiple targets for him to move between and stay locked onto. Next, I want to show a couple of video games your athletes can play. And in this first one, they have to get their marble through a maze and into a hole. And each level gets more difficult as they introduce multiple marbles and various obstacles. So there's a big cognitive component to this, along with having to control their balance and sway. And this one can be pretty tough because when he sways around, he's not moving the marble directly. He's tilting the maze itself. And as the maze moves, the marble rolls with gravity. Last, we have a skiing game, and in this, they just have to sway to keep on course to finish the level. And with all the activities you can do on this balance machine, you can also put a piece of foam like an Arex on top of it, or even a tilt board underneath for increased difficulty. So the last thing to talk about is the overall plan of care. You're going to start your athlete with this training just like any other injury when they present to you in the athletic training room. So that means that they've been able to return to school and they're relatively symptom free or have low symptoms with normal daily functional activity or school activity. Like any injury, give them a good, thorough evaluation looking for cardiovascular, VOR, and vestibular impairments. And if you find abnormality, go ahead and treat them appropriately. Always start out in the sitting position, even if there's no symptoms in that position, because then you're basically teaching them how to do the other exercises. As soon as they can perform the exercises in a position with tolerable symptoms during and no adverse symptoms following, move them to the next level of difficulty. Now, keep in mind that they may be able to tolerate doing these exercises in standing, for instance, but when you try to move them into tandem or moving around, it's too difficult. And in that case, keep them in standing for a couple days before you move them into that more difficult position again. And keep in mind that they may have other components of their rehab that day, including cardiovascular conditioning, strength training, or even non-contact team drills. So plan these interventions around those other aspects. And always consider that if your athlete's old enough to drive and they've been released for driving, you don't want to overstimulate them right before they drive home. So you might have to consider a 20-minute rest period or so before they leave.